Hello everyone and welcome to today's webinar. Before we get started, I'd like to go over a few items so you know how to participate in today's event. You've joined the presentation listening through your computer speaker system by default. If you prefer to join audio over the telephone, just select phone call on the audio section of your control panel and the dial-in information will be displayed. You can submit text questions at any time. Just type them into the questions box of your control panel and we'll address them later on in the presentation. If you prefer to ask your question verbally, you may have the option to do that. We'll take a look at that later on. But I would now like to introduce your host, Bryn Dalmao, Vice Chair of the Huntington Society of Canada National Board. Welcome, Bryn.
Thank you very much. Welcome, everyone. It's my pleasure to introduce today George Yohrling from the Huntington Disease Society of America. George joined the Huntington Disease Society of America in October of 2012. At the HDSA, George serves as the Senior Director of Mission and Scientific Affairs and is responsible for all HDSA mission-related programs such as the Centers of Excellence, Advocacy, Research, Education, and Social Services. Before coming to the HDSA, he spent 4 years as a scientific director at CHDI Foundation in Princeton, New Jersey, where he worked to identify new drug targets for HD. Before CHDI, he spent 5 years as a scientist on the Central Nervous System Drug Discovery Team at Johnson & Johnson in Philadelphia, working on novel therapies for Alzheimer's and Parkinson's disease. George received his PhD in pharmacology from Wake Forest University and did his postdoctoral training in the Department of Neurology at Massachusetts General Hospital, Harvard Medical School, in a laboratory of Dr. Jang Ho Cha, where his research focused on understanding transcriptional dysregulation in Huntington's disease. Please join me in welcoming George.
Thanks, Bryn. Thanks, everyone. Thank you, Huntington Society of Canada, and for inviting me, and for all the families that are taking some time away from what's a really pretty day here in New Jersey. Hopefully it's pretty where you are, pretty fall day, to hear a little bit about science. So go from there. I guess there are some housekeeping slides here. Oops, sorry. Oh, yeah, a little fast. We'll get there, promise. For folks, I'm not sure we covered this, but if folks are on the phone, hopefully on the right-hand side of your computer screen, you will see a menu box where you'll have the opportunity to type questions in the red shaded area. So at any time during my presentation, please do send a question if you have one while you're thinking of it, and I'll do my best to get to the questions at the end of the presentation. And Bryn and all, I would just, I don't know if you want me to do this, but I'm happy to do this. I'm sure the Huntington Society of Canada would like to thank their sponsors that make this day and other educational activities in Canada possible. So a big shout out to Rose Pharmaceuticals, Wave Life Sciences, Vacinex, and Unicure for making all they do to help make days like this possible. And really, it's days like this that are my favorite thing to do. In my position at the Huntington Disease Society of America, is to go around and, particularly lately, as probably most of you know that are on this call, it's a pretty exciting time in the HD drug discovery space. So I want to spend the next 45 minutes to an hour with you, trying to give you an update on the hope and progress that's going on in the Huntington's disease clinical development pipeline. So, kind of before I get into the clinical trials and exciting research findings that have kind of captivated our community, I wanted to spend a couple minutes talking about the Huntington's Disease Society of America and what we do. And this is probably very much a shared mission that we have with the Huntington Society of Canada, is that we want to improve the lives of everyone affected by HD. And we do this in a kind of multifaceted approach. Bryn mentioned in my position as the Director of Mission and Scientific Affairs, we have an acronym of to kind of summarize things that, resources that we use or provide to families to help them get by and to provide that hope. So we provide clinical care through our network of multidisciplinary centers of excellence, which we have now 53 around the United States. We have robust advocacy efforts where we have even a bill called the HD Parity Act in the Congress. Sadly, there's a little thing called impeachment and elections coming up where a lot of these bills are kind of languishing, but we will persist and we will continue to fight and try to get the Parity Act passed for our families in the United States. We support education, whether it's days like this, which is fantastic for families, but even more importantly, for providing resources and training for care providers, whether it's doctors, nurses, occupational therapists, genetic counselors. We have a robust pipeline of programs that we have done or are currently working on to make sure that families don't go around, aren't the only expert in the room when they go and talk to their doctor. I know that's a huge frustration for families. And finally, and maybe most importantly, is to provide that day-to-day network of local support for families, whether it's through a network of support groups and social workers that HDSA supports. They're really, the social workers in America, I'm sure this is the case in Canada, they really are guardian angels for HD families, providing that local support and care and just the knowledge of what's accessible or available for families locally. I'm in New York City. I might know what's going on in New York, but to understand the long-term care facilities and all of the different clinics and doctors and nurses in Kansas, I don't know that. So that's where we really rely on our network of social workers. Anyway, so that's HDSA. But I'm here to talk about mostly research, and that's what you've kind of dialed in to hear about. And I want to just spend 1 minute to talk about how HDSA supports research. And like the Huntington Society of Canada and others, we have a robust research grant portfolio. HDSAs, I won't go through all of it, but we have a limited budget for research grants, and HDSA has made a very strategic decision to focus those limited dollars on having a more patient or human-centric approach for the research that we fund. So we really want to understand the true HD model, and that is humans. Mice and rats and monkeys, while they might make kind of interesting models, they don't get HD, but humans do. So we really have focused a lot of our research dollars over the past 7 years on better understanding people. We think things like this and all the late-breaking news, it's critically important that we get the facts out there in a language that's very easily understood for families. So HDSA supports research webinars and a proud supporter of hdbuzz.net. If you haven't checked out that website, please do. As well as a weekly blog, very short. If you only have a couple minutes to want to know what's going on in the community, we have a weekly blog from my colleague, Dr. Leora Fox at HDSA, where we kind of summarize everything that's going on that we think families should know about. At HDSA, we want to facilitate clinical trial participation, whether that's through going to centers of excellence where most of these clinical trials are happening. We've launched a few years ago HD Trial Finder, which I'll talk about in a minute or a few minutes, and even have partnered recently on a new program called HD Legacy with Harvard Brain Bank and CHDI Foundation to facilitate organ and brain donation from HD families. I think most importantly, a relatively new initiative that we work on that I want to highlight is called HDQO, and that's giving families voices in the research and drug development process. And this is something that was born out of a little bit of frustration, with companies, more and more companies coming into the HD drug discovery space, which is a great thing. They were coming to groups like the Huntington Society of Canada and HDSA saying, hey, George, we want to talk to a patient that meets this criteria. Oh, we would like to talk to a caregiver in California that understands juvenile Huntington disease. And, while we could do that, it's still a lot of work to kind of, de novo or on an ad hoc basis try to identify these people and wrangle them up for providing guidance to pharmaceutical companies. So we formed, next slide here, yes. A couple years ago, a HDQO was born, and that was a coalition with the European Huntington's Association, the Huntington Disease Society of America, and the Huntington Society of Canada. So the three major organizations around the world came together, formed this coalition to basically provide an at-the-ready group of patients and caregivers that represent the global community, to provide that voice, a voice to the pharmaceutical and biotech companies of the world that are working in the drug HD space, to make sure that the trials aren't just about them, but they're for them, and they're designed with them specifically in mind. Here's some pictures. It might be a little hard to see, but here's a group down on the left, some Europeans and mostly North Americans meeting with unicure in preparation for their gene therapy study. I will talk about that in a little bit. And the middle pictures and the right picture are actually pictures from us in London at the kickoff in February of 2018. I think you even see the former CEO Bev there in the front and middle picture, not paying attention while Ed Wild and Sarah Tabrizi are talking, which is kind of funny, but I digress. This is the picture. This is the full team back in 2018, meeting with Ed Wild and Sarah Tabrizi and the team at University College of London to learn more and get trained about the upcoming Roche ASO study. This group is amazing, and they are really behind the scenes putting the HD feedback or fingerprint all over the clinical studies that are currently in trials or will be soon. They have had meetings with Roche and Wave and Novartis and unicure, and have provided feedback to HCI on enrolled protocols. And most recently, we've even expanded representation to Africa, Australia, China, and South America. And so just wanted to highlight this as a really cool, high impact program where we're working with, as a global community, with the Americans, the Canadians, the Europeans, and even other countries and continents to really make a difference and accelerate drug development. So that's HDQO. And I thought it was important to kind of mention to everyone. But enough of that. Let's talk about the exciting stuff, and that is the clinical trials for Huntington's disease. Most of you, I don't know where everyone's understanding of clinical trials and the processes, so I just thought I'd take a minute to just talk through what it takes to make a medicine. And it's a lot of work. It takes a lot of time. It takes a tremendous amount of money, and it fails way more than it succeeds. And so, typically this starts with a stage one in drug discovery, where you have hundreds of thousands, if not millions, of drug compounds that we start with, and it slowly whittles down through preclinical development to get to clinical development, where you might have 1, 2, or 3 drugs that will actually make it for a disease area like Huntington's to go into the clinic. And so then we will start, or the companies will start, here's listing actually 5 different phases, but for the most part, what you hear about are phase 1, 2, and 3. Phase 3 studies are being typically the last study or pivotal study needed for FDA or Canadian health approval to be able to be given to patients. In the case of HD, these numbers that I have here, this is just the different major phases of clinical development and what it tests. So phase 1 trial is purely safety. We want to make sure, this is typically the first time a drug has gone into a human being, so we want to make sure it does no harm. So it's just testing for dangerous side effects. And typically this is a very small number, between 20 and 50 patients, either HD patients or healthy volunteers. These are numbers that we've tried to I estimate are typical of an HD phase 1 trial. When you go into other disease areas like cardiovascular, diabetes, or cancer, those numbers may be much higher. In a phase 2 study, you continue to monitor safety in the disease population, like HD that you hope to treat. We're also kind of exploring potential outcome measures. So, what does this drug X do to chorea? What does this drug do to the irritability that's might be in HD patients, or their memory, things like that. And the outcomes of those results will then inform the phase 3 trial design, which is more geared towards efficacy, meaning does the drug actually help the symptoms? So using the information that they gain in phase 2 to design a good phase 3, hopefully final trial that will lead to regulatory approval. And these studies tend to have hundreds of patients. In the case of the Roche study, which we'll talk about in just a minute, that has now over 800 patients. So that's just really brief clinical trial development, so everyone knows on the same page in terms of the different phases of the clinical trial pipeline. And oops, sorry about that. And so the pipeline is very full, when that's a really good problem. And I should show this pipeline. I should go back into my notes and look at the pipeline where it looked, 10 years ago. I can tell you, this pipeline is this is just a few of them. This is not everybody that's working in HD and all of the trials that are going on. It's just to give you a sense that, we have 2 FDA-approved drugs for to combat some of the symptoms associated with Huntington's. That's tetrabenazine and deutetrabenazine, also known as Austedo. And then we have a huge pipeline of different approaches, a lot focused on Huntington lowering, but also some symptomatic approaches that are in trials. It's just really rewarding when looking at this compared to 10 years ago to see just the sheer number and diversity of the pipeline, as well as this progression, leaving the drug discovery space, and the companies are actually committed in moving forward into the clinic, which is where the real dollars are spent. So it shows a huge commitment from the companies to move forward in the clinical studies. There's a new study. I mentioned that the FDA has approved 2 drugs for the treatment of the chorea associated with Huntington's, tetrabenazine and deutetrabenazine. As if you can tell from the name here of this drug Ingrezza from Neurocrine, valbenazine, it's a very similar drug. It works in an identical manner by inhibiting what's called a VMAT2 transporter to alter levels of dopamine in the brain of HD patients. And the idea being here is that you inhibit this, you could potentially control the uncontrolled movements seen in HD. So this is a study that actually should be starting. We don't have information on the whereabouts yet, but you should be hearing more about this study very soon. This will be a phase 3 study. It's already approved for the treatment of tardive dyskinesia. So we know it's safe. It's moving straight to a phase 3 final pivotal study where they'll be looking at changes in total maximal chorea. You can see the eligibility criteria here. So stay tuned for this. So that's a symptomatic approach that is about to go into the clinic. There are a number of other symptomatic HD approaches that are in the clinic or we're awaiting results. They're shown here. They're in different levels of clinical development. So one I want to bring to your attention is from Azavan Pharmaceuticals, a small biotech in Pennsylvania, where they're testing this drug. They're calling it SRX246. Basically, it's a drug that blocks a receptor in the brain, and we have data, the field has data to suggest that when this receptor is blocked or antagonized by this drug SRX246, you could potentially positively impact irritability and aggression that's seen in people, and then we know that this is a very common symptom in some HD patients. So, and it's an unmet or untreated condition or symptom. So we're very excited to see the study is done, and we're anxiously awaiting the results of this study to see what and if and what the next steps will be. There's another study testing an antibody for a protein called semaphorin 4D from a company called Vasinex. This is the Signal study people may have heard of. And the idea here is this antibody will block this protein, kind of sequester it, and prevent it from causing brain inflammation. So there's a hypothesis that there's, similar to Alzheimer's and multiple sclerosis and Parkinson's, that there is some sort of neurologic brain inflammation in HD, and if we could kind of dampen that inflammation, we could potentially impact the course of the disease. And finally, a small biotech company in Boston area, Sage Therapeutics, has just launched a very early phase 1 safety study looking at an NMDA agonist. This is a drug that they believe if they block the activity of this receptor, they could maybe improve cognition. And we all know this is certainly something that's impaired in HD and other diseases, and could have a huge impact on the disease potentially if it works. So those are some symptomatic approaches, but really what everyone has kind of been talking about, and I know in the press and in families, is the idea of targeting Huntington. So in the case of the drugs that I just showed you, all of those drugs, while they may in fact improve symptoms associated with Huntington's disease, they were not designed with Huntington's disease patients in mind. They just simply weren't. It just so happens that they might work to combat some of the symptoms in HD, but the drugs now that are being developed to lower Huntington are designed specifically for HD patients. I'm talking to you a little bit about this. So we'll have to go back to Biology 101 or 8th grade biology, where we talk about the very central dogma of cell biology to get us started. So, and that is DNA makes RNA makes protein, right? So this is what makes the world go round, and our bodies are bodies. Think of it another way, is the DNA is your cookbook. Inside the cookbook are different pages are recipes, and each recipe, when executed properly, makes a meal, in this case, a cupcake. However, inside that cookbook, inside your DNA, you could have a typo. And instead of a teaspoon, you could have, could say tablespoon. And that could really screw up your recipe, right? In the case of the RNA. And just that simple mutation could make some really weird looking cupcakes. They still kind of might taste like cupcakes and sort of look like cupcakes, but they're not great looking cupcakes. So think of it in the case of Huntington's disease and the genetics of HD, we know what causes Huntington's disease, and that is a CAG expansion in the Huntington gene on chromosome 4. So we have the Huntington gene in all cells in our body. Everyone, whether they're HD positive or negative, we have this gene, and we're still learning what it does. And we have some ideas, but we know that when this expands too much, greater than 40 CAGs, that the patient, if they live long enough, will develop symptoms of Huntington's disease. So this expansion of CAGs is translated into, or transcribed into a Huntington recipe with expanded CAGs. Normally, you'd have around 20 or so CAGs, and that will allow you to make a normal Huntington protein. But when it's expanded to 40 or more, it's making this expanded protein, which can be kind of similar to those exploded cupcakes that we showed on the last slide. So what do we want to do? In other words, all of the approaches that I'm going to talk to you about right now, we want to get rid of these weird exploded cupcakes. And the way you can do it is, well, you can throw out the cupcakes, you can rip up the bad recipe, or you can just toss out the whole cookbook. Well, we're not going to right now talk about messing with the DNA, and we're not going to talk about approaches for targeting the protein or the meal here. All we're going to talk about today are the things that are in the clinic right now are all focused on effectively targeting that bad recipe or the Huntington RNA. So their approaches are varied, and we'll talk through some of these. So the ones that are most advanced are these things called antisense oligonucleotides, or ASOs, and they involve an intrathecal administration of the needle or a spinal tap, lumbar puncture. That's what intrathecal means, where the drug is injected into the spinal column, and the idea is that the drug flows up through the spinal fluid, or cerebral spinal fluid, and basically bathes the brain in drug, and the drug can penetrate into the outer layers of the brain. So Wave Life Sciences and Roche Genentech are using the ASO approach. There's an approach that just started this last week from Unicure, and others like Voyager and Takeda will be doing a viral gene therapy approach, which involves will involve a neurosurgical approach where there's small holes will be drilled into the skull, and injections will have to occur directly into the brain to deliver a virus that will express Huntington lowering drugs. And then finally, companies are also working on, wouldn't it be great to have a small molecule, either in the form of a pill or a liquid that you could take orally that could lower Huntington. And we'll talk briefly about some approaches there, companies that are working on that. Hopefully everyone can see this. This is a really fantastic slide courtesy of my former colleague Doug McDonald at CHDI Foundation, where just highlights a list of companies that are taking many shots on goal on just lowering Huntington. You know, we've got 18 or 20 companies right here that are working on all sorts of different approaches, whether it's ASOs or viruses or even small molecules to target the Huntington RNA or in some cases DNA. And you can see where they stand in the clinic. Several are in the clinic, some are, this is actually now in the clinic, and several are approaching very rapidly. So the way Roche and Wave work is that I mentioned they're targeting the RNA with ASO drugs. The idea here is that, you know, here's the message. The ASO drugs are not small molecules. If you took them orally, they're just never going to get into the brain. Your body will destroy them. They'll never reach this recipe in order to degrade it. And what happens in the case of the ASO is once it's injected and gets into the brain cells, the neurons, it'll specifically designed to find that recipe and only bind that Huntington RNA. And your body's got this amazing, you know, amazing self-defense mechanisms, and one mechanism it has is that it knows that RNA is single-stranded. DNA is double-stranded, RNA is single-stranded. And when this ASO drug binds and forms a double-stranded complex, your body says, not cool, this shouldn't be here. It recruits a bunch of little enzymes and proteins together, and the end result is it will degrade and chop up the RNA, which will lead to hopefully less protein. So, what happened on December 11th, 2017, I'm sure is no mystery to all of you. You've probably seen this slide before, so I apologize, but it's so exciting that it's worth showing over and over again. You know, when it was presented to a room full of patients and a room full of scientists at the CHDI conference in March of 2018, about half of them filled up and started crying, because this was one of those moments that was a landmark moment we've been waiting for. And what it is it shows that here's on the left-hand or vertical axis is mutant Huntington levels in the spinal fluid of HD patients. This is data from the phase 1/2 Ionis study testing the first Huntington lowering drug in man. And on the right-hand or the lower axis, you see the 5 different doses of the ASO, the Huntington lowering ASO. And basically what you see is here, in the placebo, those that did not receive any drug, their Huntington levels remain static and serve as a control. They didn't, she was showing where they are, and this is the reference, they didn't decrease. But with increasing doses of the ASO, we see a statistically significant decrease in the levels of mutant Huntington in HD patients. This was awesome data, and this was data that you know, enabled, basically triggered Genentech and Roche to license this from Ionis to pursue it into a phase 3 clinical study. And you know, it wasn't just the HD clinicians and scientists that were excited about this. You know, it got all over the press. I'm sure you saw it. And the paper highlighting these data was just recently published in May in the New England Journal of Medicine, the world's most, you know, reputable, outstanding medical journal. You can see that there on the left, and of course it got covered by, this is the article from the National Public Radio, what was on CNN and all over national news, whether it's in England or Canada or the US, covering the exciting breakthrough. So those results have led to the creation of the Generation HD1 study, which is a phase 3 study of the drug, which is now called RG6042. RG stands for Roche Genentech. And this is a study of now 801 patients aged 25 to 65 with diagnosed manifest Huntington's disease. All the sites in the United States have finished their recruiting, and I'm sure this is still going on in Europe and maybe in Canada, but this is a 25-month study with 3 arms to it, where there'll be approximately, 250 patients or so in each arm, which one group or one cohort will receive placebo, come in every 2 months and get an injection of placebo, so just no drug every 2 months. Another group will get the ASO every 2 months, the high dose, 120 milligrams, I believe. And then another group will alternate between the high dose and the placebo. So they're actually going to be getting the drug every 4 months, so 3 times a year. So this is the actual clinical trial protocol here. This is, like I said, a 25-month study. We don't have, obviously, results because we're still recruiting. But it's a hugely important study. It's a phase 3, and it's going to answer it. I like this slide I borrowed from Genentech because it kind of outlines exactly the questions that we're hoping to answer in this study. One is, what's the optimal dosing strategy? Is it every 2 months? Can we get away with every 4 months? If we could get away with every 4 months, that's a huge reduction in the burden for families and patients, as well as healthcare providers in terms of dosing. Are there any safety concerns when we treat a large group for a very long period of time, right? The phase 1-2 study was a much smaller patient population. We're continue to monitor safety over a longer duration of time in this patient population. And I think most importantly, not that they're all important, safety is paramount, but we need to show that Huntington lowering effect that I just showed you correlates into some sort of sustainable clinical benefit. Does Huntington lowering improve a clinical outcome in HD patients? We're going to need something like that if we want regulatory approval for this drug. There are a number of other things that Genentech and Roche are working on, obviously beyond the Generation HD study, but there's a natural history study kind of answering the question is, how does HD progress? To try to help us understand if we can treat the symptoms earlier or before they actually occur. There's going to be a PKPD study, which stands for pharmacokinetic and pharmacodynamic, big fancy words that just basically say, what does the body do to the drug, and what does the drug do to the body? So what the body does to the drug is pharmacokinetic, and what the drug does to the body is pharmacodynamic. Those studies are going on, as well as an open label extension of folks so that we can monitor what happens to them over a long time. So the Roche Genentech approach is what they also would refer to as a non-allele specific approach, meaning it lowers both the good and the bad Huntington. So if you can remember, and I'm sure you all know this, is that in the case of most Huntington's disease cases, the child inherits, has a 50-50 chance of inheriting this disease from their affected parent. The case here is the father with the Huntington's disease gene in red. And you get the child inherits 1 copy of the Huntington gene from the father and 1 copy of the Huntington gene from the mother. And the Roche Genentech approach cannot differentiate between the good and the bad gene. And as I mentioned to you, that this Huntington gene is in every cell in the body. We know for a fact that in the case of mice, if we knock out, completely obliterate the Huntington gene from mice as they develop, they will not be born. They die in utero. So we know that this protein, this gene, is utterly important in our development of our brain and other organs. So there is a hypothesis that maybe we want to have an allele-specific approach where we just target the red gene here, the expanded gene, and leave the unexpanded healthy protein-producing gene intact. And the WAVE approach does that. They have 2 studies underway, Precision HD1, Precision HD2, where they're using antisense oligonucleotides similar to Roche. And the way they're doing this is by not targeting the CAG, because remember, the normal Huntington gene has a CAG expansion of 20 or so, and the expanded Huntington gene has obviously a CAG expansion of 40 or greater. So the drug can't just target that necessarily. So what are they doing? How are they going to try to differentiate the bad gene from the good gene? They're doing it with these things by exploiting these things called SNPs, or single nucleotide polymorphisms. And they're basically just these subtle DNA changes that are throughout our body. They're usually, benign. They don't do anything. They're really what makes us, what makes me, and what makes you. I use an example of a very common SNP, and I was actually in Buffalo last week giving a presentation, and there were 40 people in the room, and including myself. And I asked the question, I wish we could do this here, I'm just thinking of it, is how many people dislike the taste of cilantro? And 4 people raised their hand, so 10% of the people in the room. And it couldn't have worked better, because it's known that 10% of people in the world really, including myself, really dislike the taste of cilantro. It tastes soapy to them. It's an awful taste. And the reason it tastes soapy is that those folks, including myself, have a SNP. And it's a SNP and an olfactory receptor that just, for whatever reason, makes cilantro taste like crap to us. So it's not harmful. It just is what it is, but it's a known genetic change. And so WAVE has identified, as well as the scientific field, that there are these SNPs 1 and 2, that are only found on the mutant Huntington gene at different locations. And they're not found on the normal Huntington gene. So they've basically used this like a GPS signaling device, that they're able to create a drug, an ASO, that will just specifically target one or the other SNP and bind to that. And going back to that slide where I showed you that the ASO, once it binds to the RNA, doesn't like to be double-stranded, it will chop up the mutant Huntington based on the fact that it bound to this SNP. And important thing to point out is that not everyone, just like in the case of the cilantro SNP, not everyone has a SNP, SNP1 and SNP2 in their mutant Huntington gene. It's been found that around 70% of people that are gene positive for Huntington's disease have either SNP1, SNP2, or both, which means that the other 30% that don't have one of these SNPs would not be candidates for the precision HD1 or 2 study, right? So if you put the ASO in there, it'd be going around looking. If you didn't have one of these SNPs, it'd be looking for one of these SNPs, and it wouldn't find it. So it would not. It should not lower the Huntington in those patients that are devoid of the SNP. So just to kind of recap, here is kind of the approaches for the current ASO approaches in the clinic. Both are intrathecal or spinal tap lumbar puncture delivery. The Roche Genentech is in phase 3, whereas WAVE is currently in phase 1/2. The Genentech approach is non-allele specific, so it's going to reduce both the good and bad Huntington, whereas WAVE should more specifically reduce the bad Huntington. The Roche approach, while it may lower the good and the bad, the drug is designed to be a potential treatment for all patients, whereas I just mentioned the WAVE drug is really reliant on the presence of these SNPs. So if you don't have a SNP, you aren't a candidate for one of these 2 studies. So they only have the potential, they have the potential to treat 30 to 70% of the patients. All right. So that's an ASO approach. What's really noteworthy is this idea of gene therapy, which is really hot in the news right now. And recently, a couple gene therapy approaches have been approved, most recently in spinal muscular atrophy. Zolgensma, a drug from Novartis, and Avexis to treat spinal muscular atrophy, which is all over the news because one dose of it costs something like $2.1 million, the most expensive drug ever created. And that's partly in part because this involves what we think will be a one-time injection. And the way this gene therapy approach will work in Huntington's disease is companies will use a virus as a vector, basically a delivery device for a new gene. In the case of Huntington's disease, it's a gene that's a microRNA, a little piece of RNA that's going to bind to, similar to ASO, bind to the Huntington RNA. And remember, when RNA is double-stranded, the body doesn't like that. It'll chop it up and get rid of it. And the drug will be recycled to go find another RNA and chop it up. So the Huntington microRNA, or this gene, new gene, is put into this harmless vector that is, called an adeno-associated virus. And this virus will be required to be injected directly into the brain under a neurosurgical approach. So this is a gene therapy. It requires surgery. It only requires one intervention, we think. We don't know for sure if folks would need other kind of additional dosing over time. But this is a permanent approach. The potentially bad thing or worrisome thing about this approach is that it's permanent, right? And it's once this drug is in, or this virus is injected, it's in. There's no shutting off the expression of this microRNA. So uniQure is just announced last week that their trial, their phase 1 study in HD patients has begun, is recruiting in the United States. And these are data shown from an HD mini pig. And as you can see, this is an actual HD mini pig. It is not mini at all. It's about 250 pounds. These are big boys. And they're used because of their big brains. And, it's easy to inject the virus into a mouse brain, which is like the size of a pencil eraser, and get that virus to kind of go everywhere in the brain. But it's a different story when you have a big brain like a human or a pig. So a pig might be a good model to test how well some of these gene therapies diffuse through the brain and get to different brain regions. What you can see is when they inject their gene therapy into the striatum of these, which is what we think that they will do for uniQure, you get almost a 70%, 68% reduction of the mutant Huntington protein in regions where the virus was injected. And then if you go further away from the brain, for the region that was injected, like the occipital lobe, you see there was no reduction in protein, meaning that virus kind of stayed locally and focused on where it was injected and wasn't able to diffuse out to other regions of the brain. So with that, these data was announced, just I mentioned last week, that their drug called AMT-130 is starting a dose escalation double-blind study in the United States. It's very small to begin, 26 patients. 16 will receive the drug and 10 will receive the placebo or an imitation surgery. And you can see the eligibility criteria here. Several sites have already been started recruiting, and there will be several more to come. And so if you want more information on this, it'll appear at HC Trial Finder as well as on clinicaltrials.gov, which we'll talk about in just a few slides. So we've talked about an intrathecal approach, which involves spinal tap. We've talked about gene therapy approach, which involves kind of intrastriatal injections, neurosurgical approach. And it's my bias, and just this is purely my thoughts here, is that the holy grail of HD treatments, in my mind, would not involve a surgery. It would involve a pill. You could take orally or a liquid. Wouldn't need needles or surgeries. It would allow you to titrate or adjust the dose. So if you need to lower Huntington a little bit more, you get a little bit more of the dose with a wide therapeutic window of safety. This drug would, when taken orally, would get into the brain and would lower Huntington throughout the body. As I mentioned, Huntington's in every cell of the body. So we've been very focused as researchers on understanding what HD does or Huntington gene does in the brain. But remember, it's expanded in other organs like the heart and the liver, and it's likely having an effect in these different organs. So to me, it's only it's a little bit of common sense that we probably or might want to think about lowering mutant Huntington throughout the body. And have a more holistic approach. So to me, that would be an ideal kind of holy grail of potential drugs. And luckily, we have now work from pharmaceutical and biotech companies to show that in HD mice, this might be possible. So companies like Novartis and PTC Therapeutics are working to identify orally delivered small molecules that get into the brain that could potentially lower Huntington and modify the course of the disease. And this isn't, just like dreaming. This is like they've got some compounds that do this, and the hope is to be in clinical trials in the coming months as the calendar turns to 2020. So stay tuned for that. I think this is the kind of the final area of research I just want to talk about, because I get this question a lot, and to kind of give you an idea of where I think the field is going. I get this question from families like, hey, George, how is it that I have 40 CAGs and I developed these symptoms at age 40, but my dad had 40 CAGs, but he didn't develop symptoms until he was 70. What gives? And that's kind of represented here. What we know really well about Huntington's disease is that the more CAGs in your gene, the Huntington gene, the earlier the age of onset of the disease, right? But as you can see, particularly in the lower ranges of CAGs in the 40s and 50s, there's a lot of noise here. There's a lot of variability. And what is it? What is it about these people, those that develop the symptoms much later than the average, or those that develop the symptoms much earlier than the average? What is it about them that either protects them or kind of works against them in developing symptoms? And in 2015, a landmark paper was published on something called the Genome-Wide Association Study, or GWAS, and it basically looked at the DNA across thousands and thousands of HD patients. And what they found were they identified these genetic modifiers, and that is basically these genes that are, when modified in Huntington's patients, can either accelerate the onset of disease or delay the onset. And if we could kind of recapitulate that in the case of a drug, maybe we could create a drug that could push somebody who would normally develop disease at 40 up to somebody who would develop it at 70. All of these genes are, which was interesting, were found to be involved in the way our body handles DNA. And it's a kind of burgeoning field in HD research, the idea of DNA repair and how Huntington binds to these DNA proteins. There's some amazing work being done out of Ray Truon's lab with Tam and Mayuri and others in Canada that are looking at this, as well as Rachel Harding at the University of Toronto, looking at how DNA and binds to Huntington and affects the interaction with DNA repair proteins. So they've identified these proteins that are affecting DNA repair. What we see is that they affect DNA. What we know is that if you take a blood test at age 18, to see if you have the Huntington gene, and say in the case of this little person here, they had 42 CAGs. Over the course of your life, if you have another blood test years later, your blood test will still come out as 42 CAGs. But over the course of your life, you may have inherited 42 CAGs from your mother or father, but if we were able to tap into your brain over the course of your life, we would find that neurons inside your brain would that CAG would start to expand to 50, 60, and even greater. This also happens in your liver. This is something called somatic instability, or repeat expansion. And there are companies like Triplet and Locus 23 and even CHI Foundation that are working on ways, hypothesis that if we could stop this expansion, we could, and keep somebody that inherits a CAG of 42 and keep them at 42, we could potentially delay the onset of the disease. And that is shown, I apologize, it's a little sciencey, but it's to me kind of really clearly here. And this is a later stage HD brain. And the case here is a patient that had 40, you can see they had 41 CAGs and 16, right? So the expanded copy here and the unexpanded copy here. And they're looking at the different regions of the brain. And you see that in the striatum, the region of the brain that's most affected by HD, in these later stage patients, they have these huge repeat expansions. We're talking up in the range of 1,000 CAGs in the striatum of these patients. Here's another patient with 51 and 20, and you can see the similar expansion in the striatum as well as in the cortex. But look here, in the cerebellum, this is the region of the brain in the back of your brain that's relatively unaffected in HD. The neurons look relatively healthy and don't die and form aggregates like they do in the striatum and cortex. And you can see that there's little to no somatic instability or expansion in the cerebellum. So could we develop drugs that prevent this from happening, that prevent this somatic expansion or instability from happening, make a striatum look more like the cerebellum? We could potentially modify the course of the disease. So this is an area that I think in the next few years you'll be hearing a lot about, not only from researchers, but pharmaceutical and biotech companies that are moving closer to the clinic with therapies to tackle this type of hypothesis in Huntington's disease. So with that, that's my research. I think I want to turn it over to the HSC group because they've got some polls that want to query to everyone that's participating, ask a few questions of them. I'll turn it over to you guys. So yeah, here it is. So we wanted to take a kind of make sure you're awake and I didn't put you to sleep, and see if you are a yes or no. Hopefully you can see this on your screen. Are you part of Enroll HD? So if you won't mind, on your screen, select either yes or no. I'll give everyone a few minutes or a few seconds to collect that. And I'll let you guys go to the next question whenever you think that we've got it. Most folks answering. All right, so there it is. Hopefully everyone can see, people can see the results. So 59% are not part of Enroll HD, and 41% are. Not bad, but we can do better, and we'll talk about Enroll HD in just a minute. All right, so what's the next question is, I believe it's, yeah, have you ever participated in a clinical trial, I should say. So yes or no, not even, doesn't have to be Enroll HD, but any clinical trial, even something outside of Huntington's disease, have you ever participated? All right, so 61% have not. That's not bad. I was expecting it to be much greater than that. Typically, I think in the United States, the participation rate is quite low across the population of participating in a trial. So, that's not bad at all, I don't think. All right, and then finally, we have a question here, and I'm going to talk about this in the next slide. Have you ever heard of, I should say, have you ever heard of HD Trial Finder? HD Trial Finder, either yes, no, or maybe. Ooh, 13% yes. Okay, 17% maybe, but 71% have not heard of HD Trial Finder. Okay, well, that was awesome. This is actually really informative. And I think that will kind of take me to kind of nice segue into the final slides that I have for you all. If I can present here again. So many of you had not heard of Enroll HD, and I just want to introduce, it's an exciting time. There is going to be a lot of trials that are happening, not only in manifest, but pre-manifest patients that are not sick or showing symptoms. We need a lot of people that are at the ready to participate to make sure these trials don't languish in terms of their recruitment. One of the ways we, think that this can happen is by having the community participate in Enroll HD, which is a global observational study. It's a platform for which all future HD research or clinical trials will be launched. It's an annual visit. It's meant to be not too kind of time consuming or invasive. Typical first meeting or first appointment could take over 2 hours, but after the first visit they should be shorter. And it's general health questions, a neurologic exam. There's a blood sample that is taken for genotyping, meaning you find out whether or not, you don't find out, but the blood is taken and your CAGs are screened. The doctor in the clinic that take the blood never find out your genetic test, nor do you. This is not a way to be genetically tested. It's simply a way to know your genetic status inside the database, which you are never identified. You're given an HDID number. So it's never tied back to a particular person. So you're all kind of de-identified anonymous fashion. And as of today, this is a global platform which has over 19,000 participants, which sounds fantastic, but we need more. We need more. Well, that's my next slide. You know, these are just the goals of Enroll HD, and you can read them. But really, to me, the most important thing is we've got a lot of things in the pipeline. We want to make sure we get answers for whether or not these drugs work as quickly as possible. And one of the biggest hurdles to drug development is the recruitment of clinical trials. Some trials just never even fully recruit, and they fail because they're unable to get enough people into them. We can't let that happen in HD. I don't think we will let that happen, but we want these trials to happen as quickly as possible. And Enroll HD, I think, is poised to help us do that. Why? Because this is a magnet. This platform is a magnet for Huntington disease companies interested in seeing if their drug works in HD. And these are just some of the companies working in this space. When I travel around and I go to meetings where there are other rare disease organizations trying to get companies involved in their disease, they're just desperate for help. They say, well, what can we do to get a Roche or Pfizer or somebody involved? They're looking at our disease. And the answer is always, one of the first answers is build a registry, build an observational study, and they will come. And this is proof that they have come. I use this as a real proof and point. This is something that happened in the United States with the natural history study in the selection of their sites. You can see in blue that the 7 study sites that were selected. And just look around like, oh, that makes sense. Northern California, Sacramento, Denver, Colorado, Houston, Texas, a huge city, East Coast, New York City, some of our largest HDSA centers of excellence on the periphery. And then there's this guy here, Hereditary Neurologic Disease Center, Wichita, Kansas. It's clearly not there because it's right in the middle of the country, because we've got Colorado. And I asked families, why do people think that was selected? And I think the answer is they're the fourth or fifth largest enroll site in the entire world. They have hundreds and hundreds of families and patients that are participating in the enroll study. Roche and Genentech went to where the patients were. And, families, I think, whether it's in Canada or the United States, they want sites in their backyard. And one of the good ways to ensure that you have study sites or studies to participate in your backyard is to participate in Enroll. It doesn't make sense for a company to, open up a clinical trial site in Montana if there are 2 patients in an Enroll site there. But it's just an inefficiency and maybe a waste of their time and energy. Whereas, maybe would be better to open their site in Wichita, Kansas, which has 400 or 500 patients, because their likelihood of getting the patients they need in their study is greater. And so Enroll HD, well, I mentioned they have 19,000 folks that are participating. What we want to do moving forward with Enroll is focus on the pre-manifest, those that are not yet symptomatic. And you can see they're doing a good job today, but we need to do better, particularly focusing on this yellow wedge of folks. There's a representation of the percentage of people in the beginning of 2018 that were pre-manifest that were participating in Enroll. And you can see as of today, this is almost doubled. Around 20% of the folks today are pre-manifest, we're moving in the right direction, but we need this to be bigger, because we'll ultimately want to run trials in gene-positive individuals that are not sick, because we never want them to get sick. And that will require far more patients than we have right now participating in clinical studies. So I'm going to flip through this for time. There's lots of local and observational studies beyond what I talked about that are Huntington lower and are symptomatic studies. They can be found in HD Trial Finder. And this is a resource that we built at HDSA, not only for the Americans, but all of North America. So it lists all currently recruiting clinical trials in North America. If it's still ongoing, but it's not recruiting, whether it's in the United States or Canada, it's not going to be on our database. We talk on a very routine basis with all of the sponsors of these clinical studies, like Roche and Wave and Unicure, and states about the current status of their recruitment. When they say they're no longer accepting patients, even though the study is still ongoing, it's no longer an option for you to call. So we don't want to, set up expectations. We want to manage expectations and not disappoint you. You finally picking up the phone and say, all right, I'm going to participate in this Genentech study, only for, the university in Canada to say, I'm sorry, we're no longer recruiting. But my website says, the website clinicaltrials.gov or something says that it is. We maintain that database on a routine basis to kind of update that. And so I encourage you to go to hdtrialfinder.org because Canada is the only other country that we built this for, our partners our neighbors to the north. And so only studies in North America will be found in there. European sites are currently not in HD Trial Finder, but you'll find information on Canadian Enroll HD sites and Clarity and not HD Legacy because that's a US only. But we'll also look to add other kind of smaller local studies. There's a lot of research going on around the world and in Canada that maybe don't involve a drug. And it doesn't mean they're not super important. So they could be just looking at a new clinical assessment or outcome. Like maybe which we do need, are new outcomes in the clinic that can track disease progression or the onset of disease in pre-manifest patients. We're not going to have pre-manifest studies if we don't have better outcomes, and we need people, and only we're going to have better outcomes if we have people participating in studies like that. And those studies are coming or underway, and studies like that will be in HD Trial Finder. You might not find them in other places like clinicaltrials.gov. So I hope that you found this informative, and I hope that this day is just kind of the beginning of your continuous education about what's going on in the HD field. You in Canada are blessed to have such an amazing organization, the Huntington Society of Canada, to turn to, and their website. We also at HDSA are trying to increase all of our resources, and they're of course available and mostly applicable to everyone in North America. So certainly take a look there for more resources. I mentioned it before, but I highly recommend families take a look at HD Buzz. You can go to hdbuzz.net. This is Ed Wild and Jeff Carroll's brainchild, where they cover whether it's press releases or hot topics or papers that are coming out or recent results from the clinic that are getting into the news or press releases, and they're distilling them down into language that the lay families can understand. And basically, what does it mean to you? What do you have to worry about here? What should excite you or concern you? And then also just mention participate. We need families to participate. The easiest way is to participate in Enroll HD. This is at sites throughout Canada and the United States. You can find them where these study sites are at hdtrialfinder.org, or you can go to the, I know at the Huntington Society link down below, clinical trial locations. You can also find information that's close to you in Canada. So with that, I think that's my last slide. Yep. So I kind of wanted to open it up to questions and see if anyone has anything online that I can try to address if I didn't get to it.
We do have some questions. Thank you, George, for a very informative, very interesting, and some excellent analogies in that presentation. It was really insightful. Our first question that's come in is, how would someone or a company get access to the Enroll HD data set?
Yeah, so my understanding is the Enroll HD data set, which is constantly evolving and getting bigger and bigger as more people participate. They're up to like iteration 4 now, is that they can submit a proposal, an application to a committee. It's like a scientific review committee. I forget the exact name, but what that company plans to do with it is reviewed by a kind of committee of peers from academia and CHGI, and then they determine whether or not they want to grant access to it. That's my understanding.
Great, thank you. A second question that's come in, And obviously people are very interested in some of the research you've shared with us because they're wondering, is it possible that we could learn results before a trial time commitment is up, that we could learn things in real time as they're unfolding?
Yeah. In real time, I don't know. I don't know that if that's necessarily possible in real time. Maybe someone has some ideas other than me. I know I get this question a lot because of what happened with which I didn't discuss, related to the treatment of ASOs for spinal muscular atrophy. A few years ago, a study testing ASOs in children with SMA. This is an Ionis drug in partnership with Biogen. This is, I think, is a 36-month study that they ended early. And they ended as an interim analysis. The data suggested that all the children on the placebo were getting sick and all of the children on the drug were getting better. And, it was unethical to continue. And that that's always a possibility. I don't know, of the trials that are going on if interim analyses are planned. I mean, that they would never announce that, I don't think, because that could kind of create some sort of bias within participants. That like we're approaching the 18-month point, like they're gonna take a look at these data. It better be better, we better be good, so that they hopefully we don't have to do this for 3 years instead of 18 months. But yeah, I don't know of a situation where we could release clinical trial data live.
And I think that's a great point. And I wonder, you did highlight already Dr. Rachel Harding, one of our wonderful scientists here in Canada. She shares through Lab Scribbles, so an online notebook. And I think what you've highlighted for us is that sometimes in the basic science research world, we can share things a little more rapidly, but often in clinical trials, because we're working with human subjects, there's the ethics concerns, there's issues of bias, that often does require waiting until the study is complete, unless, as you've said, there's an issue of safety that's being discovered.
Yeah, Rachel, I'm glad you brought that up, and that's a fantastic thing that Rachel does, and others, sharing their results in basically real time so you can see exactly what she's doing. It's fantastic, and that type of facilitation and openness is really amazing, and it's running rampant, I think, through the HD community. We're very an open, sharing research community, as opposed to some other these areas that I've even worked in that are more competitive and cutthroat. The HD community in generally is quite supportive of each other and open to opening their doors and their notebooks to one another to try to get this disease, treated.
Yeah, we're very fortunate. This last question, actually, I think I may be able to field a little bit here. So the question, and it's a great one, is that if drug treatments become available, we assume they will be incredibly expensive. What role will the HSC be advocating in government and insurance companies to cover the medication? So I'm happy to share with everyone that this is something as a board we're really aware of. We've just completed our strategic plan for the next 5 years, and advocacy is a big part of that. I can't provide you with any specifics right now because we don't know costs, we don't know when drugs will be available, we don't know which insurance companies we would be working with, but certainly to put your minds at ease that absolutely that is a big focus for us, and we know it is going to be a big commitment that we are ready to take on as we move forward. George, I don't know if you have anything you wanted to add to that.
Yeah, no, I mean, I think I tell families, well, I really hope this is the problem we have, that we have disease-modifying therapies that are really expensive, and we just have to work on getting them in the hands of the doctors and the patients. We will get that solved. I'm very confident. To have a drug that is, these drugs will be expensive. But families will not bear the cost of there's no family that will pay $2.1 million in an SMA drug gene therapy. These companies will work with payers and are doing that. And I think the companies in the HD space are having those conversations and will do their best behind the scenes to make sure that if and when these drugs are approved, that they're made accessible and affordable to families. And those that cannot afford will get, I'm sure, companies will have, just like we've seen in the case of other times when it was Teva or Lundbeck, where they couldn't afford their chorea medications, they were made available through other means for families that couldn't afford it. So I'm confident that will happen again.
You're right. That would be an excellent problem to be encountering. So we're going to wrap things up now. And George, thank you so much for your time and your expertise today. I think we really learned a lot, and again, appreciated the way you could translate the science into really meaningful information for all of us. So thank you.
Thank you for inviting me.
Oh,
appreciate the time.
Our pleasure. I would also like to thank our sponsors, Roche, Wave Life Sciences, Vaccinex, and Unicure, for making today possible that we could bring you this excellent information. And finally, on behalf of the Huntington Society of Canada, I would like to thank all of you for joining us. We hope that this was both informative and inspiring, and we hope you enjoy the rest of your day today. Thank you, everyone.